Right. Thank you very much for your patience. We will get this evening's webinar underway. So first, as I mentioned, my name is Suvir Venkataraman. I'm the host for this evening. And I'd like to introduce you to tonight's panel. So we have Dr. Geetha Venkat, but unfortunately she's held up in a bit of traffic, so she'll join us in a little while. Mr. Raj Joshi, who is the clinic's senior embryologist, Ms. Rachel Dyer, who is the clinic's lead nurse, and we're very fortunate to have one of our old patients, Daisy, joining us to give you her side of the story. So this evening's agenda is really to cover a bit of background, which I will provide, and the clinical impact. So the topic is ethnicity and how it affects fertility, and in particular South Asian ethnicity. And so then we'll discuss the clinical impact and then what the data have shown. And last but not least, actually what we can do about it. So how to help yourself and how to help others. The event will be recorded and posted on our website in due course if you want to refer back to it if you missed something. We will have question and answers at the end. Feel free to raise your hand or you can submit questions via the panel. If you want to stay anonymous, that's absolutely fine. So, without further ado, the introduction. So, when we think about fertility, you know, the factors that affect fertility, the things that we often think about are, you know, the person's age, their family history, their overall health, and whether there's any sort of family history of infertility, so, you know, genetic issues that might be passed down. And then when we start to dig a little bit deeper, so typically once, you know, someone attends a fertility clinic, they learn about their ovarian reserve, whether their fallopian tubes may be blocked, how long they've been trying for, or what's known as their duration of infertility, the sperm parameters that we see, and the genetic issues that we actually find. Why is ethnicity important? It doesn't usually come across as one of the main factors. So there were a couple of recent studies that were very large and looked into trends in infertility treatment. And one was commissioned by the UK regulator of fertility, the Human Fertilisation and Embryology Authority, the HFEA. And in their study, which is of all the cycles of IVF and donor insemination, basically all infertility cycles performed in the UK, they found some interesting trends when it comes to fertility and ethnicity. So they found that Asian patients tend to have an increased risk of ovulatory disorders, including polycystic ovaries, and we'll come on to that later. They tend to represent a larger proportion of IVF users. So, you know, across the UK, if we look at the population, about 7% of patients access IVF. About 7% of the UK population is Asian. But if we look at all the IVF users in the UK, so the UK does about 80,000 cycles of IVF, about 14% of those will be with Asian couples. And they tend to have lower pregnancy rates with IVF. And this is very important. We'll come on to this in a bit. And one of the sort of causing factors is they may have less access to assisted reproduction, so IVF and other treatment options, or they may also have increased risk of premature ovarian aging. What does that mean? And we'll discuss that in a bit more detail when we look at the clinical impact. And then the other finding that was interesting was that they found that there are fewer Asian egg and sperm donors. So again, you know, the Asian population in the UK is about 7%. And as we said, you know, there's a disproportionate number of Asians who use IVF treatment. But unfortunately, there's only about, out of all the egg donors and sperm donors, there's only about 4% who are Asian and 5% who are Asian sperm donors. And what that means is there's not enough donors for Asian patients. And sometimes people end up using a white donor as a substitute, which is obviously not ideal. So on the clinical impact, and Dr. Venkat was meant to cover this, but I will, in her absence, I will try and do my best. The we talk about the patients, Asian patients having poorer clinical outcomes. But, just because you're of a particular ethnicity doesn't mean there's anything wrong with you, or that, there's something that makes you infertile. There's got to be a scientific or medical basis for this poorer outcome. So what causes it? So one of the issues is that there is a high prevalence of polycystic ovary syndrome, so PCOS. It's an endocrine disorder, which means that women tend to have irregular periods, they don't ovulate regularly, and it causes them essentially to be less fertile. And it's disproportionate in South Asian. So the incidence of PCOS in Caucasians is about 22%, but in South Asians, it's about 52%. So that's 1 in 2 tend to suffer from PCOS. So PCOS can cause things like obesity, diabetes. It can make you not ovulate. It can cause you to have hirsutism, which is sort of facial hair growth, and basically general sort of skin conditions like acne, because it causes an imbalance in your hormones. And so that means that any of those patients who have PCOS are less fertile, and they will require some form of help. So that's the first part, the first challenge that we face. The next is what we talk about is we refer to as something called ovarian reserve. So, in school, most of us will learn that women are born with all the eggs that they will ever have, and that they lose them throughout their fertile life. And this is referred to as your ovarian reserve. So you start with a large reserve in your ovaries, and it slowly declines with age. Now, we measure this using 2 indicators. So we measure a hormone in your blood, which is called anti-Mullerian hormone, or AMH, and we look at this on pelvic scan. So we look at the actual ovaries using ultrasound and count how many antral follicles are present on the ovaries, and it gives us an indication of your ovarian reserve. And as you can see on this graph, the 2 factors, your AMH and your antral follicle count, will decline with age. Now, this is a general trend in all ethnicities, but actually if we control for age, so if we look at women of the same age and other fertility factors across ethnicities, unfortunately, the antral follicle count is lowest in Asian women of the same age. So essentially what we're saying is, if you take an Asian woman and a Caucasian woman of the same age and all fertility factors, the Asian lady will unfortunately is more likely to have a lower ovarian reserve. And so essentially she appears to be older in terms of her fertility. So this can be referred to as premature ovarian aging, and the difference can be up to 5 years. So what that means is, when we think about reference ranges for fertility, so if you talk to your GP or fertility doctors, they'll tend to say, a lady's fertility starts to decline after the age of 35. And that's true for the general population. But unfortunately, not everyone's the same. And so we just talked about saying, Asian women, the fertility tends to decline earlier. So then the reference range has to then change. We need to take that into account to say, actually, in Asian women, it might start to decline in their early 30s rather than in their mid 30s. And so what happens is, effectively, because we use right now, we use the same yardstick for everyone. We say that, after 35, it starts to decline. If we see Asian patients at 35 versus Caucasian patients, the Asian patients will have poorer clinical outcomes, even though they're the same age. And then there are, various other issues that come up. So, things like your ovarian reserve declining earlier, the genetics that we inherit, so there is an overrepresentation of some genes that causes this to happen. Those things aren't, they're not really in our control. We can't change them. That's the way you are. But we can, the things that we can control can help. So things like lifestyle changes and also seeking help or advice earlier are the only things that we can control. So that's what we will encourage you to do and to spread the word about it as well. So I'm going to hand over at this point to Raj, because I've spoken at length, to go through what the data have shown us. Thanks.
Thank you, Suvir. So basically, the research is showing that Asian people, Asian women, have a lower pregnancy rate and birth rate, up to a third lower than Caucasian white women with IVF. They are also looking at why this may be. You know, they're looking at the cumulative pregnancy rates as well, which are lower, and they think it may be due to the physiology of the women. It's how they metabolize the drugs, and this may, it needs a lot of research, but it's just, they're looking at it now, and it may be the basis because they are more prone to PCOS. PCOS causes a higher chance of miscarriage because it's an abnormal disorder. We can get, you know, there's several levels of PCOS. So you could be mild, moderate, or high. And if you have high PCOS, that can mean you overstimulate with the drugs or you understimulate with the drugs. If you're understimulating, it'll take a lot longer and you'll need more drugs to actually get mature eggs. So if you're moderately suffering from PCOS, then you'll get a lot of follicles develop. But again, these may develop in a shorter space of time, and this will impact on the maturity of the eggs. And egg quality is actually determined when we're doing the ICSI. We're looking at it when the eggs are being manufactured in the ovaries. And when we're actually doing the ICSI, we notice things like granularity. We notice that when we're injecting, there should be a little bit of resistance when we're injecting into the egg. And sometimes that's not there. Also, there may be other discrepancies within the egg, which are like, you get a small vesicles within the egg called SERs, which are apparent. Also, you'll get the eggs may be mobile. They may also, you know, not like a needle being injected into them. So that is what we see when we're looking down the microscope. Also, there are differences in the outcome because if you're having a lot, if you have 20 eggs collected and you have about, let's say, 7 mature, so 7 are injected and you get 5 that are fertilized, we'll anticipate 3 blastocysts. Now with 3 blastocysts, we freeze these for you, but then a lady, a white Caucasian lady will not have PCOS and may get more eggs, more embryos, more blastocysts, and more freezing. Can I have the next slide, please? So clinical outcomes are similar in egg donation cycles. So that means that if an Asian lady is having somebody else's eggs, then her chances of pregnancy are better because she's not using her own eggs. And it also means that there is, you know, the etiology of the lady is actually affecting the egg quality. Okay, Asian patients tend to have a longer duration of infertility before seeking help. So they will try at home. I think it's still taboo to discuss and talk, though the younger generation is reaching out and is very proactive. It's just, you know, I think it's getting to them to tell them, come and see a specialist, come and have your blood hormones done, come and have a semen assessment done for the men. Also, there is another thing. There's a study that was done in Hyderabad by the Cellular and Molecular Biology Center. And basically, they looked at the men who suffer from infertility, and they found that there was a high frequency of gene deletion on the Y chromosome, which is the male chromosome, especially in the area which is called the AZF region, or the azoospermic factor region, which is responsible for sperm production. And they studied like 973 Indian men with normal sperm counts. And they looked at the AZF region and looked at the deletions. And 29.4% had gene deletions in that area. This may be due to something called endogamy, which is basically marrying within a community and not having diversity within that community. So if you're marrying within the community, there's not going to be a mixing of the gene pool. And this is causing, a high incidence of gene deletions in Asian men, which is potentially underlying this issue. So can I have a next slide, please? Okay. So we can't control the ethnicity or the genetics, and infertility is nobody's fault, but there is help available. So it's best to get a checkup when you're younger for both of you, to find out, whether it's suitable for you to come in and freeze eggs and take it from there. Rachel, over to you.
Thank you very much. Thank you very much, Raj. So this was the slide that I was meant to be starting, but thank you for the introduction and leading me into it. One of the things I want to say, can you all hear me? I hope you can hear me all right, yes? Right, okay. Is that infertility is a fertility disorder. So it's something that the reproductive system is not working well. And therefore what we shouldn't do is blame ourselves or blame our partner. It's something that we can hopefully address. There is research happening all the time, so things are changing. So the bottom line is not to cause blame. When someone is unwell with a sickness or a disease, you look for answers to try and fix it. And we should be thinking the same thing about infertility. It's something that hopefully man is getting more knowledge and getting resources that hopefully will turn the corner in some of these issues that we can hopefully fix. And data is changing and improving every day. So again, one of the things to stress, it's not a blame. It's not to blame anyone. The next thing I wanted to say is, so we were saying about what to do. So the thing to do is get information. The world is getting smaller because of the internet. There's lots of information out there. There's lots of resources out there. So we should make use of what's out there. Try and find out what the basic information is, because that gives you a standard so you can actually see if there's an issue with yourself or not, or your partner, or even a family friend. So if you find out what is expected, how the body is supposed to function, when you should be having children, and how your fertility is supposed to be, then you should have some sort of comparison that you can see, or maybe identify that there is a problem and that needs to be addressed. And then one of the things, of course, you need to do, or you should probably do, is talk to your friends and family members, because again, family members in ethnic communities and also in Afro-Caribbean communities tend not to talk about these things. We don't talk about fertility, we don't talk about puberty, we don't talk about periods, we don't talk about sex. But these are things that we should be talking about so that we can help each other overcome these issues. It's not something to shy away. And like Raj was saying, the younger population are probably becoming more open about things, but it's something that we should all grasp and try and be more open and seek more help and promote more help for each other. Other things I want to say about your diet. You can also look at your diet. When you're in the Caribbean or when you're in Asia, you're eating different foods, but you're not working as hard. So because now you have, transport, you have cars, you hardly walk anywhere. So again, your lifestyle has an impact on making whatever the situation is, can make it worse. So again, consider how you look after yourselves. Try and eat healthily, try and maintain a good height and body weight so you're not overly overweight, because that adds more stress, more problems, more medications required, and it just makes it harder. But I think the key thing I truly want to say today is that you need to seek help earlier. As it was mentioned in the slides, is that the fertility rate for normal people kind of declines from 35 onwards, and they're thinking in the Asian women, again, there's more research coming out that it might be sooner. So the thing is to start earlier. We can freeze our eggs, and then when you have met the perfect partner, or you've settled in your life that you want to have a child, then you've got eggs already stored. So these are things that we need to talk to the younger people about, to try and do things earlier and get the information out there. Even get yourself screened, have a fertility check where you have a scan and a blood test to check the hormone levels, so we can actually see if there is an issue. The men should have their sperm checked, so you can again find out if there is an issue. And all these things we can do, but one of the things we should try and do is talk, and not to be quiet about it. As it says, it's good to talk. Thank you.
Thank you very much, Rachel. So at this point, I would like to hand over to Daisy, who is one of the clinic's patients, and we think she is a superhero because she's done it on her own. But I'll hand over to Daisy so she can give you her own view of it.
Hi everyone. Just firstly, I don't know, can everybody hear me? I've got a fan going on. I've got Cocomelon on in the background, so it's keeping the friends entertained. So I hope you can all hear me. And apologies in advance, because obviously the end result, which we're all going for, is children at the end of it, and you can't mute them. So yeah, so I came to the practice, I think it was 2018. I first came when we had when there were open days that you can attend, and I came along to one, and it was really informative. Dr. Venkat was there, and something for me clicked that this was the clinic that I wanted to. This was the clinic that I wanted to start my journey with. So for me, as an Asian woman, a few things. I guess a little bit of a taboo around IVF. Not only that, I think also I did this on my own. I'm not married. I decided to go down the IVF process on my own with a sperm donor, again in sort of like the Sri Lankan community, which is what I'm from. Again, a little bit of a taboo about it. So the uncertainty of, not so much the uncertainty of the end result, but I think it was more to do with how my parents, family, etc. would deal with it. So in all honesty, the whole how it affects IVF and fertility in ethnicity didn't even occur to me at the time. I had all the other stuff going on. But again, the clinic were really great. Dr. Venkat was really good. She even said, if you want to bring your parents along, I'm happy to speak to them. Also highlighted that it's not as taboo as one would think. More and more women in Asian cultures are going through IVF, and also on their own. So I started the process towards more into 2019, and had a few rounds of IVF. It's been really interesting to hear all of the research and where we're at actually from this webinar, because I've related to quite a few bits with it in terms of like the overstimulating, and like just because of my body, how it was, and the follicles and the quality of the eggs, etc. So, and there was the learning process as well, because obviously, unlike a couple, if I was in a, if I had a partner, hello, all right, baby, and give me 2 seconds. And if I was been in a couple and I'd been trying to conceive and then we weren't getting the results, it just literally came in blank. It was like, I was healthy. There is a family history of diabetes, being Asian, but otherwise healthy. I was a bit overweight, I guess. The one thing that lockdown really helped for me was I got healthier. I was on furlough. I started cycling everywhere. I live in central London. I lost 2 stone just by cooking and eating and cycling around. So again, I didn't even plan the weight loss in terms of IVF. I just did it. It just happened. So that could have contributed as well, because the round of IVF that I finally did, which was successful, was with my twins, and that was when the clinic opened up again. I think they opened up back in May of 2020, and I got in contact in the June. Dr. Venkat was like, well, if you can start next week, your timing and everything's great. I was like, I'm on furlough. Yes, I can start next week. And my rounds of IVF, they were putting in 2 embryos just to increase the chance that one would take. As you do, obviously there is a chance that there's twins, and by the time I had a 7-week scan, there's 1 heartbeat and then there's the second heartbeat, and then you kind of just go, okay, you don't expect it, but then you kind of think, okay, 2 for the price of 1, as they say, and then that's Oliver and Abigail. So yeah, as I said, it's been it was. Suvir said before, and Delia and several people at the clinic say superhero. Not at all, for people who are watching this who have either had kids before or haven't or whatnot. You just do what you do. Like, I haven't had kids before. This is all I know. All I know is twins. You just get on with it. Yeah, of course, I'm on my own. I'm back to work full time, hence the hair. I've just come from work and I've sat down. The twins, I will show you them quickly. They're not going to appreciate it. There's 2 sweaty babies in high chairs currently, one watching Coco Melon and the other one very intrigued as to what's going on. So, it is what it is, but, you wouldn't swap it for the world. And I think, as I said, it's been really interesting listening to, I have been feeding the twins, but I've been listening to what the panel have been saying today, and it's really sort of an eye-opener. I think in terms of myself, I focused so much on the community, my parents, what it was going to be like, and the actual getting pregnant stuff about it. And there's more research is great, because I think although, and the clinic were great in, from my first round of IVF, and they took a lot of learnings with how my body reacted to the drugs. Dr. Venkat straight away was, let's change the drugs. Let's not give you like what we would give, I guess, a normal person. Let's give you reduced so it doesn't stimulate as much, overstimulating then the follicles. So there was a lot of learnings in that, but I can see now that obviously all this research now would mean, maybe would I fall them pregnant quicker? Obviously, I wouldn't change it for the world, because I was supposed to fall pregnant when I did, and I have my 2 beautiful children that I have now. You can also see, most probably you might be able to tell from the pictures as well, that my children are Caucasian sperm donor. So again, it shows, to be fair, I wasn't too bothered with, in terms of sperm. I was just basically trying to get sperm, and so I wasn't specifically going for Sri Lankan or Asian sperm donor, but I remember from when I was looking, there was hardly any, and obviously you've got to be really quick, because they can only supply to X amount of families or X amount of women, so to speak. So yeah, that's pretty much my journey, really. It's quite easy to say on the flip side, or that's pretty much my journey. It was a journey. But yeah, like, the clinic were great, and they're not paying me to say this at all. We're all very sweaty, and I'm still sitting here talking to you. They're really great. They're really understanding. Even from going from like speaking to parents, family. Like, I was very lucky. My parents came. They spoke to Dr. Venkat, really open, honest, and so I wouldn't have been able to do it without their support. So for anyone, if there is anyone who's female and on their own thinking of doing it, it isn't a taboo. More and more people are doing it, and you'll be pleasantly surprised as well. So yeah, that's me, really.
Thank you very much, Daisy. That was tremendous. We have 1 child, and that's hard enough. So twins on your own, can't imagine. But
Okay.
yeah, as I say, it's what you know. So So thank you all for listening. And now I'm going to turn it over. I'd like to thank everyone at the clinic because, we make, everyone makes this place go around, and it's tremendously hard work. And I think all our staff really care about what they do. And that comes across when we talk about it. So with that, I'd like to turn this over for questions. And Dr. Venkat she snuck in and joined us a bit late, and I covered her slides. I hope I did a reasonable job, but we'll see. So, we're happy to take some of your questions. I've had a couple through already. So I've seen that someone's got their hand up. So is it Jinsey? Do you wish to ask your question over audio, or do you want to type it out? I'm happy to do either, if you want to do that. Oh no, your hand has gone down. Okay. So the first question we've had is, so we talked about premature ovarian aging, and then we talked about egg donation and actually how the outcomes in egg donation appear to be quite similar irrespective of ethnicity. So the question is, but what if the Asian lady has an Asian egg donor? How does this level the playing field? And I'd like to pass this to Dr. Venkat, if that's okay.
Yes, I think that's a very good question because we have in our clinic, people using, I'm talking about Asian couple or Asian women using Asian donor eggs, and some couples and some women use Asian women using mixed race donors or Caucasian donors because they have mixed marriages in their family, and they have because of that they have mixed race children in their family, and that's why they choose these donors. That is the reason. It's not that they want to make designer babies or anything. There are reasons, specific reasons for that. And we find that usually this is correct. This is a good observation because when people use Caucasian donors, even the Asian recipient, and they do much better than women using Asian donors. Because it is, even though we check the donor for everything like hormone levels, AMH levels, and age factor and everything, and BMI, smoking status, everything which can affect eggs, we do. However, at the end, like Raj pointed out, it's difficult to find out the quality of the eggs. And there is no assessment of the quality of the eggs. So there is no way we can know about it beforehand. Then when we use, sometimes we say, we have 18-year-old Asian donors. And, embryologists will tell me, where are you bringing this donor from? Then I say, she's only 18 years. Her eggs are supposed to be the best eggs in the world. But no, they don't produce good results sometimes. So I don't think anybody has done studies comparing Asian donors and white donors, how they are doing. And also we have to compare, of course, the recipients, because what is the status of the recipient, whether the woman has whether she has got normal uterus or is full of fibroids, or whether she had endometriosis, and all the other factors will come into play. And similarly, and the same thing applies to Afro-Caribbean donors and recipients. The success rate is said to be low. And again, many recipients have fibroids, which reduce the success rate, as we know. And donors also, again, egg quality varies from donor to donor, even in the same age, because then it's difficult to assess the quality of the eggs, and we find the rates, pregnancy rates are different. Having said all these things, the success rate with egg donation is generally better than women using own eggs when they are in their 40s or early menopause or premature ovarian aging cases. Of course, donor eggs are always better. But if you want to increase the success rate, maybe use white donors. That is another thing, but I'm not suggesting it. This is sort of, I mean, this is what we have noticed. Maybe I think this is a stimulation for all of us to do another research on this topic, because I think our clinic has got a lot of data on this. Unlike other clinics, which is full of Caucasian population, our clinic has good demographics, and and we can do research, and from the data we can produce some good results and the conclusions. So that will for the future.
So if I can just add to that, there was a study, it's not a very large study, there was a fairly sort of small study on comparing outcomes in egg donation cycles. And it showed that, as you just mentioned, it showed that clinical outcomes were more comparable in egg donation cycles across ethnicities. But there was still a difference, but it was not as big of a difference as in non-egg donation cycles. And so what tends to happen, if we talk about donors, because they're younger, we tend to compensate essentially by using younger donors. So in a Caucasian, we could get away with a 35-year-old donor, but in an Asian, we might end up using a 30-year-old donor. So we're sort of compensating for the sort of premature ovarian aging. The next question that we have is, during ICSI, how do you choose which sperm should be injected in the eggs that are collected? I'm going to ask Raj this one.
Basically what we do is we look for the most normal looking sperm. That's all we can go on, because unfortunately they're not labeled as normal or abnormal. We can only go by looks, and the most normal looking head without any artifacts on the midpiece, a normal say tail, and moving well through the PVP. Now PVP is basically a solution which helps slow the sperm down so we can visualize a normal sperm. So that's how we do it. We are on higher magnification when we're selecting the sperm, so we can select the best looking sperm. And there is another, if the sperm is very abnormal, there is something else we can do called IMSI, which is using a higher magnification to select sperm which doesn't have any vacuolation in the head. And this actually helps overcome some of the barriers that we see at lower magnification when we're just selecting sperm for ICSI. So we only try to pick the most normal looking sperm to us. And we have the World Health Organization, which actually has pictures, etc., which we use as reference to help us pick the most normal sperm.
So we have a follow-up to this, because tonight's audience are very well educated, Raj.
That's great, love it.
We're going to put you on, in the hot seat. If that's the case, you can't tell in ICSI, whether the sperm are actually normal or not. Why don't more clinics use IMSI or PICSI as standard?
These are newer techniques which are coming out. And again...
So Raj, sorry, if I can just interrupt, if I can ask you to explain what they are, that would be helpful.
Yes, sure, not a problem. IMSI is, like I said, we're using higher magnification to select sperm with fewer vacuoles within the sperm head. So it's a more normal looking sperm but has vacuolation. We're probably doing IMSI because the morphology of the sperm is less than 4%, considerably less than 4%, maybe 1 or 2%. That's why we're using IMSI. ICSI is basically where we're selecting a normal sperm and injecting it directly into the egg. ICSI is basically using a medium called hyaluron, and they're saying that sperm which are normal and usually stick to the hyaluron, and this is sperm with fertilization capability. So they stick to the hyaluron, and we go in and pick up the sperm. Now, with PICSI, there is a special dish available, and this we prepare the sperm to collect the fast motile and a tiny amount of that is placed into these dishes, so we can actually select the sperm that are bound to the hyalinone, which is in small discs. Now, these are new techniques, and new techniques need a lot of data to be collected and proven to be successful. And this is what's happening now, because you've just got back from ESHRA, Suvir, and there was a big thing about PICSI giving you a slightly better edge. So research is being produced, and we're moving towards more evidence-based. So it will become more routine, but again, a lot more studies are needed.
Thank you very much. Yeah, that makes sense. We're not, basically, they're sort of new techniques, and we start in a selected group of patients, and then as we see the benefits and we can sort of demonstrate the benefits in a wider group of patients, it will become more routine. Right, the next question that we have is, what are some of the infertility conditions that South Asian women face? It's a fairly broad question. I think we covered some of the, the higher incidence of PCOS and sort of lower ovarian reserve, diminished ovarian reserve at the same age. I don't know if Dr. Venkat, there's anything you wish to add to this in particular?
Yeah, that is right. The commonest conditions of polycystic ovaries, as everybody knows, the incidence of polycystic ovaries is 22% in Caucasian population, whereas in an Asian population, the incidence is 40%. So it's nearly double the incidence. And we all know that there is always somebody in your family, if you think of it, there is always somebody with diabetes, and there is always some woman with polycystic ovaries. Where that it is that common. That's what I'm trying to tell you. And polycystic ovaries, premature ovarian insufficiency, and of course, the Asians can also have fibroids, which can cause problems. And some women also have endometriosis. It doesn't mean that Asians have polycystic ovaries so that they don't have any other condition. They can have other conditions called interfering with fertility, such as fibroid of the uterus and endometriosis in the peritoneum or in the ovaries. Generally, endometriosis is another difficult condition. It can affect the quality of the eggs, and it can sort of reduce the number of eggs, and also it interferes with implantation. So it affects the fertility in all aspects. So, and this condition is never curable. We can only control it. And that's why we say, you have your family, your grandmother will say when you are young, because before the endometriosis and other things become very difficult and they become more severe. And you see in women over 35 years, the endometriosis spreads and they have all adhesions everywhere in the pelvis. We call it frozen pelvis. And even to clear the endometriosis in the pelvis, it is so difficult. Nobody would like to touch a patient like that. What I mean is operating you with a woman with all these severe adhesions and endometriosis, because endometriosis makes all the organs get stuck to each other. When you open the abdomen, you see that the ovaries are stuck to the uterus and the intestines are stuck to them. And then everything is covered like a filmy adhesion. And, you touch something, everything bleeds. And so these conditions can affect anything else. And then lastly, we also have immune conditions, autoimmune diseases. It can affect any woman in, say, over 35. This becomes more common, and it affects the Asians as well as Caucasians and in Afro-Caribbeans, because it doesn't selectively pick any ethnicity. So immune issues are common. So in addition to the special issues, there are the normal infertility issues, which can also be present in the Asian population. We must remember that.
Thank you very much. The next question that we have is, how many eggs would you expect a typical 39-year-old Asian woman to have? And is there anything that we can do to increase the number and quality of the eggs available?
Yeah, it is. I mean, it's like one size fits all. I can't say every 39-year-old woman will produce 10 eggs or 5 eggs or 20 eggs. I had a 48-year-old Asian woman who produced 28 eggs at the age of 48 years. But that doesn't mean that all 48-year-old women will produce such a number of eggs. And similarly, 39, it depends on how many eggs you have got. What is your ovarian reserve? And if you have lots of eggs, say, for example, your antral follicular count is something like 20 or 25, or even then the anti-Mullerian hormone is also in that range, 20 and 25, then you are likely to produce 20 eggs. But if your anti-Mullerian hormone and antral follicular counts are less than 10, you are likely to produce 10 eggs. So that is the number. But like I said, there is no test to check the quality of the eggs as one gets older. The quality change. All the patients tell me, doctor, I'm very fit. I go to the gym every second day and I run other days and I only eat home cooked food. I'm a vegetarian and I don't eat this, I don't eat that. I only eat vegetables and fruits and I have maintained such good health. Do you think my eggs will be good? Yes, we are what we eat. However, that doesn't guarantee that your egg will not go through the aging process. Aging process is nature. We can't fight against nature. That is why we say, look, have your children early. If you are not able to do that, now you have another option of fertility preservation and use that technique. So put some eggs in the bank. Like don't worry about putting money in the bank. That's not important as far as fertility is concerned. You have to put the eggs in the bank. Later on, they will come very handy, especially if you are 39 years old, you have done it earlier. If you want to have 2 children or 3 children, then, you might be able to have your first child when you start trying now or in a year's time. What about the second child? Then you will be struggling. So if you have some eggs in the bank, that's the best insurance policy. So I think that's what I would say when you're at that age. Every month is important.
And just to touch on the second part of that question, is there anything one can do to increase the number and quality of eggs available?
Yeah, there are some supplements. I can say that, if the egg number is low, you can take supplements like DHEA. This is supposed to increase the number of eggs. And supplements like coenzyme Q10 and melatonin, they improve the quality of the eggs. And also lifestyle changes, because we all live in this modern world, which is full of stress, and we eat all the convenience food, which contains all the preservatives and other things, chemicals, which is not good. And we are exposed to all these pesticides, and the pollution in London is the worst. So our eggs are all exposed to all these chemicals. All these pollutants or chemicals, like drinking water from plastic, it contains paraben, and it becomes, when it sort of mixes with water, it becomes parabolic acid. It is very dangerous to the egg as well as to the sperm. So, but at the same time, we have to live in this era. We have to live a normal life. And therefore, we do all these things. But if you want to improve things, good lifestyle, good food, good nutrition, and that's what. But you can't keep it better like this forever. We must remember that, okay, if you do that, okay, it might last for a few months, but nature takes over at once.
Thank you. And I think the last question that we have is, if a woman freezes her eggs in her 20s, what is the guarantee those eggs will all fertilize in later years when matched with sperm? Do you do any quality checks on the eggs? My understanding is that not unless an embryo is created can you determine the egg quality. And I think I can ask Raj and then Dr. Venkat to field this question, please.
Hey, like we've said before, unfortunately, there is no test to determine the egg quality. If only there was, if only. Unfortunately, there isn't. If you're freezing eggs in your 20s with vitrification, the technique that we're using, snap freezing, we expect a good percentage of those eggs to survive on warming. So you're freezing 20, we'd expect a minimum of 16 eggs to survive, if not all 20. And then fertilization is comparable to normal fertilization with ICSI. And because the eggs have been frozen, unfortunately, we can't mix the eggs and sperm together. We can't do IVF. We have to physically place the sperm into each frozen egg because the freezing process actually hardens the outer shell of the egg called the zona pellucida. So ICSI has to be done on each of the frozen eggs. And roughly our fertilization rates are between, I'd say, 60 and 80%. So we expect at least, if say all 20 eggs survive, we expect anywhere between 16 to 18 eggs to fertilize normally. Dr. Venkat?
Yeah, no, I agree with you, Raj. I mean, you are the embryologist, you have said everything. Don't expect all the eggs to fertilize. That is the first statement I would say, because I tell them, look, the number keeps going down. And that is the reason, if you want to make one healthy baby, we recommend you freeze 20 to 30 eggs, depending on your age. So like Raj said, if you freeze something like 15 to 20 eggs when you're at the age of 20, because when you take them out, you lose some eggs. And when you fertilize, you lose some eggs. Once they become embryo, we grow the embryos for 5 days. Then every day you lose something. And then supposing at the end you have 4 blastocysts left, or 5 even, what happens? All 5 will not be chromosomally normal. There will be some embryos which are chromosomally abnormal, so we can't use them. So to get one baby, we might have 1 or 2 normal embryos. And the next job is put them in whether that one implants or not. That is the next question. So we say, look, if you want to have a baby, you freeze 20 to 30 eggs. We don't need to do that if we can make one baby from 1 egg. So that is the reason, even at the age of 20, we say freeze at least 20 eggs. That is to protect you. But even then, I will say there is no guarantee that you will definitely have a baby. That we cannot say. But hopefully, a 20-year-old woman's chances of getting a baby from her frozen eggs will be definitely better than somebody who is 40 years, because the egg quality will go down. And the egg number also goes down. And when we take out how many will survive, how many will fertilize, everything will vary depending on the quality. But you have, that woman has got the best chance of success because she has been wise enough to freeze at the age of 20. Don't you agree, Raj?
Definitely agree with you, Dr. Venkat.
We have one last question that snuck in, which is, how many embryos for a baby on average for Asian women do you need per your data? And do you recommend PGTA? I think I'll field these myself, if that's all right. We do recommend PGTA because if you transfer aneuploid embryos, they won't result in a pregnancy. So it helps your embryo selection. The jury's out. I mean, some people are against it for various reasons, but the science is undeniable. How many embryos we recommend for a baby on average for Asian women? So if the embryos are genetically normal, there's not too much so if we have a good quality embryo, and Raj, correct me if I'm wrong on something. If we have a top quality embryo from an Asian or Caucasian lady, and everything else is under control, the implantation rate is about the same. We see a success rate of about 65%. Problem is, if you take a 35-year-old Asian lady and a 35-year-old Caucasian lady, they won't have the same number of eggs, and they won't end up with the same number of blastocysts or the same number of euploid embryos. And so you actually end up with fewer good embryos as an Asian patient. So if you take a success rate of about 65%, that means essentially you need about 2 or 3 genetically normal embryos to achieve a pregnancy. Now, unfortunately, for Asian women, that is the odds are stacked against them that they might need an additional cycle of IVF to actually get the embryos to do it. Raj, is there anything you'd like to add to that?
No, I think it's important that PGTA is done because we need to know the ploidy of the embryo, but to make sure that if one normal blastocyst goes back, it's going to increase the chances of pregnancy. So it's just one normal embryo. But to get that one normal embryo, the patient will need, like you said, 3 to 6 blastocysts to achieve that same 65% chance of getting pregnant.
Dr. Venkat, is there anything you wish to add to that statement?
No, I think both of you have covered all the points, and it's a good question because it opens your eyes. Like we don't understand science beyond certain degrees, and that's why we are doing all these things to be ready at the end so that we get a successful outcome.
Thank you all very much. So I'd like to wrap up this evening's webinar with just a quick summary. I think, as we've emphasized, ethnicity does play a role in fertility. It has an impact in that our fertility aging changes by ethnicity. So, no 2 35-year-olds or 30-year-olds or 40-year-olds are the same. And I think all the commentary you've seen in response to your questions, it's important to say there is no standard 35-year-old, that you should find out about yourself. And so we encourage you to discuss fertility, as Rachel discussed, it's important to talk about fertility and dispel the myths and taboos that are present, especially in ethnic minority communities. And clinically, it's important that you get a checkup to find out what your fertility status is. Because you might have a great ovarian reserve, like Dr. Venkat's 48-year-old lady who got 20 eggs out. Or actually, even at the age of 32, you may have very few eggs left. So each person is an individual, and we encourage you to get the right information about yourself. Please, talk to us if you have questions afterwards. Please reach out to the clinic. The next webinar that we're going to hold in September, we're taking a bit of a break in August, is going to be on artificial intelligence in embryo selection. We will post the date on our website. I'm sure that will be an exciting talk. It's a new technique and technology that we are validating in the clinic, and it looks very promising indeed, so that should be quite exciting. So with that, I would like to thank the panel for their participation. If I can stop my share. Okay. I'd like to thank Dr. Venkat and Raj and Rachel for your time this evening. And last but not least, I would like to thank Daisy wholeheartedly for your time and the fact that you're juggling twins while the rest of us are barely managing to juggle Zoom. So well done, and thank you all very much.
Thank you, Daisy. Daisy, thanks for the message, and thank you. I appreciate your lovely presentation and everything. You are a patient, like a model patient, I have to say. And thank you, Daisy.
We can't argue with the twins. So thank you all very much. Have a good night.
Thank you.
Bye.
Thank you. Bye-bye.